Good. I have nothing to disclose. Just a little background. When Brian had asked me to give this talk on ACL tears, I was psyched. I mean, this is my bread and butter. This is what I do. And then I started putting the slides together and realized that this is a week-long symposium. And I saw that he gave me 45 minutes. And then I saw that those 45 minutes were an hour after lunch. And I realized that everyone would much rather be napping than listening to me blather on. So I'll try to kind of keep you awake and keep it moving and make sure I point out the things that are sort of the most salient potentially to your practice. So the ACL, this is something that we've known about forever. Galen first brought it up thousands of years ago. The first description of an ACL injury was over a millennium ago. It was described in 2 patients back in 1850. And the first attempt at surgical repair was actually all the way back in the early 20th century. Routine treatment of ACLs really didn't become a thing until sports medicine became a thing, which was in the 70s. Early sports surgeons realized that this is an important ligament, and the people that got this were people who were doing cutting, pivoting, and twisting sports. And this is probably one of the most important things I can tell you is the ACL not only is important for instability problems, but the ACL is really protective of the knee. Without an ACL, you're much more likely to have a meniscus tear or damage your cartilage. So this is common, obviously, amongst the physically active population. It's most commonly seen in patients under the age of 30, but we live in the Pacific Northwest. Everybody's staying active, everyone's staying active later in life. So we're seeing it certainly in the older patient population. United States alone, 250,000 ACL tears. This number is probably low, this data is a little bit old, but over 107,000 are reconstructed per year, and the rate is certainly expected to climb over the next few decades as the baby boomers get older and stay active. What's interesting is overall there are more ACL tears in men than women, but this is really just because men play more sport than women, and as a percent of sports participation, females are actually 8 times more likely to tear their ACL. There's a couple of various reasons we'll go into why that may be. Different sports have higher risk of ACL tear, highest in adolescents that do cutting, pivoting, and twisting sports. American football, most common sport leading to ACL rupture amongst men. Basketball, most common for women. But across soccer as well, up to 100 to 1,000 times more likely than the general population to tear your ACL. So this is typically an active patient population. Having told you that, I saw a patient yesterday who stepped off his truck and tore his ACL. So he was not a very athletic guy. It can happen to anybody. Much lower risk in sports like obviously biking, running, swimming, things that aren't really causing a twisting type of thing. So there's just a little background on the anatomy of the ACL. That's it right in the middle there. It's intra-articular, so it's in the capsule, but it's actually extrasynovial and has quite a poor blood supply, so when you tear it, it doesn't heal. So once it's gone, it's gone. It's not coming back. Mechanism of injury. So most commonly, this is a non-contact injury, 70 to 80% of the time. There are 2 distinct mechanisms of ACL injury that are non-contact. The first is sort of a decelerating, pivoting maneuver. This is common cutting from right to left to right, as you're slowing down to get around a defender in soccer or basketball. This is a type of injury we see in football, soccer, rugby, trying to pivot and get around somebody. And what happens is the foot is on the ground, the knees flex about 20 degrees, and the quadriceps is in overdrive. It's pulling at 160% of max, and the hamstrings are barely working, and it causes an anterior translation on the tibia, which causes it to twist and turn, and the ACL can't tolerate it. The other mechanism is landing on one leg and then falling with a twisting valgus, meaning internally rotated maneuver. Again, the same type of results. Twisting pulls on the anterior tibia, pulls it forward, minimal resistance from the other stabilizers as they're relaxed in those types of positions, which can lead to a result, which can look something like this or even this. We like gross pictures in orthopedics, I'm sorry. So there's some neuromuscular studies that have been done to try to figure out why women are more prone to tearing than men. And there's a number of different things that have been looked at. One of the main things that has been talked about is women have more valgus knees. They have slightly wider hips, generally, and the knees kind of point in. And when that sort of sets you up for a landing mechanism, women tend to land more with their knees pointing in, and that puts an increased stress on the ACL. This may help explain it. This is a picture of a kid, but more preferred method would be on the left. More common, certainly amongst females, is to land in this valgus abducted maneuver, and this seems to be the main reason we found the gender difference. Everything has been looked at, hormones, age, everything, and this seems to be the one that sticks. So contact-mediated ACL rupture is a little bit different. It's typically a hit to the side. So in soccer, a slide tackle, football, a player planting and going to move, getting hit when they're not expecting it. This causes a twisting maneuver and sort of similar type mechanism, but they're not doing it to themselves. Going to kick a ball with the other leg, and it's actually the planted foot, not the one you're kicking with, that's at risk. So what do we do when one of these patients walks into our office? First, thorough history, okay? Usually occurs during sports or activity, but it could be certainly my patient who stepped off the truck who's low energy. It could certainly be work-related. See that a fair bit too, and it's usually a twisting event. So this is one of the key takeaways. So everybody wake up for a sec, and if someone comes in and they answer yes to these three questions, did you hear or feel an audible pop? If the answer is yes, were you able to continue playing your sport? Were you able to keep skiing down the hill? Were you able to continue in the game? No. And did they develop a painful effusion within the first 24 hours after injury? Those three questions, the answer is yes. Over 70% of the time, that alone will be an ACL tear. Now, it's not 100%. There could be other things. It could be a patellar dislocation. It could be a tibial plateau fracture. But this is the most common thing we see with an ACL tear. Now, chronic ACL tears are a little different. These are people that maybe had an injury, didn't like going to see the doctor. Maybe they saw a doctor and they said, oh, you're too young or too old, kind of put it on the back burner. These people often will complain of frequent giving way episodes. And one that I commonly hear is, it doesn't sound like much, but people will be doing dishes and they turn to go and put the dishes in the dishwasher and come back, and all of a sudden they're on the floor. That's a pretty unstable knee, and that's a more chronic appearing physical history. And if you look closely, sometimes they'll actually have atrophy of their quad because they're really avoiding using that leg quite a bit. So when you're doing a physical exam, try to get them to walk. And this is great if they can, but most of these people are on crutches. They're not really able to do it. But if they can, that would be great. This sort of helps you pick up what's normal for them. Do they have a limb length discrepancy? Do they have a hip issue? Are there other things that are going to affect their rehab that we don't know about if we don't have them moving? This is also really important for a couple of reasons. Number one, you check the good knee. You know what's normal for the patient. It gives you a chance to get them to calm down. Oftentimes, adolescents that come in are very apprehensive, or sometimes even you see as in kids, they're not going to let you touch them. And quite frankly, I don't blame them. It hurts. And they're afraid, I'm kind of a big guy, they're afraid I'm going to manhandle them. And it gives me a chance to let them calm down and realize that this isn't going to be too much for them. Always looking for an effusion. When the ACL tears, it gets swollen. You almost never see it without. Certainly check the range of motion. This is often limited, and it may be severely limited. They may only have 20, 30 degrees of motion because it hurts. Certainly check the joint line. This isn't really for the ACL, but the ACL is commonly associated with meniscal tears or collateral ligament injuries. Oftentimes the MCL will be involved. So this kind of perks up your attention. There might be more than just the ACL going on. Now, ACL-specific tests. There's 3 of them, and if you can do one of them, that would be great. We'll start with the anterior drawer test. This one's probably the easiest to perform. It's the least specific, but this kind of gets you somewhere. And what it is you have the patient lying supine. You guys have probably heard this before. You have the hip flexed to 45 degrees, the knees bent 90 degrees. You put the foot flat on the table and go ahead and sit on their foot. This really kind of stabilizes everything and allows you to get a good idea. Certainly this is something you want to compare to the other side as well. And then you put both hands in the proximal tibia and you pull forward. Put your thumbs right along the patellar tendon. If you pull forward and there is increased translation compared to the other side, this is a torn ACL. This is what it looks like. Examiner sitting on the side, foot on the table, pull forward. And again, this is something you have to compare to the other side. Some people have some increased laxity anyways, and so you can get a little bit of a false positive with that. This is a nice, easy, quick and dirty test to perform. Next test is the Lachman's test. This one's much more reliable, more sensitive, more specific than the anterior drawer. Also a little bit harder to perform. The patient is lying down and the knees flex about 20 to 30 degrees. You take your top hand, hold the distal thigh, your bottom hand and put it right on the proximal tibia, kind of along the side of their tibial tubercle, and you stabilize the leg and then you pull forward. Looks like this. You got to do about 1,000 of these before it really makes sense. So how do you grade that? These are graded 1s, 2s, and 3s for movement, and A and B for the endpoint. So normal Lachman's exam, we'd call a 1A Lachman's. That means it moves less than 5 millimeters, and when you pull on it, it feels like you're pulling and hitting a doorstop, okay? Now, a 2 could also be normal. That's why you have to compare to the other side. A B is never normal. If you have a soft endpoint, it's torn. So the most common thing you'll see is a 2B or a 3B Lachman's test. A 2B is what you'll commonly see with an acute injury. There's a lot of swelling. Sometimes patients won't really be able to give you a full relaxation to allow you to do it. But that's what I'm looking for. A 3B is more commonly in a chronic injury where the swelling's gone and they're sort of used to it. They'll let you pull on it. And then we have the pivot shift test. And this one, I'm pretty sure you need to do about 10,000 of these before you can really figure it out. I'm sure some of our PAs could attest to that in the audience, not to pick on you at all. This is the true test for instability. This is pathognomonic. I think we're doing a physical exam in about an hour, and really this is one you want to see someone do. I can explain it to you with words, but basically you want to grab the ankle with your low hand, bring the leg off to the side, and you want to internally rotate the tibia, put your hand up along the proximal tibia, and you're going to twist and lift the leg up at the same time. And what we're looking for is we want to bring the leg off to the side to sort of relax the IT band. This just explains it in words here. Then we internally rotate and press into valgus and pull forward. And if the femur, when you bring the leg up, kind of sags behind and is delayed, and when it comes out, that's a positive test. Now, so again, same thing, you got to compare to the other side. And this one can be a little bit difficult if the patient's real swollen. They just won't let you do it, and that's fine, just skip it. Because it's pretty uncomfortable. This is the exact mechanism that they feel when they tore their ACL. And so this one can really bother them. So pivot shift grading, grade 1 is what we call pivot glide. Again, this one may be normal. Pivot 2 is the femur jumps to catch up to the tibia as you're pulling it, internally rotated, bring it up, and rotate at the same time. Grade 3, the leg will lock. If you get a grade 3, the patient will never let you touch them again. They hate that. So next thing we want to do is we want to get x-rays, and this is for a number of reasons. First of all, I got to see if there's something broken. I had a mentor once who told me that everybody deserves a normal set of x-rays. Everybody's, they've earned that right, and he was right. I'm a knee and shoulder guy, and I alone have picked up a couple of primary sarcomas, cancers, and things like that. So not to change the subject here, but always important to get x-rays, make sure we know what we're looking at. I also want to look at the skeletal maturity, as that changes how I would fix an ACL. And this thing right over here that's circled, this is called a Sagan fracture. This is pathognomonic for an ACL tear. If you see this is pretty much an ACL tear. And what that is, it's a small avulsion of what's called the anterolateral ligament and capsule, kind of from the front and lateral, the anterior and lateral aspect of the tibia. And this is, if we saw this on the boards, that's an ACL tear. So, ACL is really a history and physical diagnosis, and the reason we always get an MRI, but the MRI is really to see what else is there. When you have someone come in and their knee is loose, I don't need the MRI for that. But I need to know if I'm going to be chasing down a meniscus tear, if the cartilage is going to be damaged, is there something else that I need to know about that I can help the patient understand is going to potentially affect adversely their recovery during this time frame. So let me back up there. That's what a normal ACL would look like on the sagittal view of what's called a T2 image here. And then this is abnormal. And there's a lot of different types of abnormal. This would be an acute injury. The one on the left there, that would be a mid-substance injury. This is probably the most common. The one on the right here is probably a high-grade partial tear. And you'll see a lot of the radiologists call these partial tears. To me, it's either functional or non-functional. So when I examine the knee and I get the MRI, if they're loose as all get out and the radiologist has read said, maybe there's a little bit of fraying there, it's torn, it's stretched out, it's not working. This is what more acute would look like. And this is what it looks like on the coronal view. The left one would be more of the proximal femoral side type tear. We see these real commonly in skiers. This is, I'm getting off the chairlift for the first time type injury. You come down, slow motion mechanism, go down, the ACL pulls off of the femoral side. The one on the right here, this is what a more chronic one would look like. There's just nothing home. There's no tissue there at all. But this is the real reason we get the MRIs right here, is to see what else is going on. I'm not sure if this has a laser pointer with it. Yeah, good. So right here, this is a bucket handle medial meniscus tear. This is a normal lateral meniscus tear here, and this should not be here. And then this right here is a bone bruise, which is classic for an ACL tear. There's always this classic ACL bone bruise pattern, if it's the typical type of injury, where there's bone bruising in the mid portion of the lateral femoral condyle and bone bruising in the posterior aspect of the lateral tibial plateau. The knee literally twists and smacks itself and comes back. See that? So what's next? That's when you send them to us. We'll take care of it from here. So what are our goals? We want to restore knee stability. We want to get their motion back. We want to protect the meniscus and the cartilage. We need to rehab their strength and get them back to their previous level of sport and play. We're pretty good at it, but you can still screw this up. At this point, ACL surgery is pretty much an outpatient surgery. Patients go home the same day. We have predictable and excellent results. The procedure is much less morbid than it used to be. It's all done arthroscopically, other than when we're harvesting the graft to recreate the ACL. It's a rapid and safe recovery with very low risk associated with it. And again, our goal is to protect and preserve the meniscus and the cartilage. Now, not everybody needs an ACL surgery. If you told me a patient comes in and said, hey, doc, listen, I just want to sit on the couch, I want to eat Cheetos, I don't need an ACL, and I'm totally fine with that. But the majority of patients are not that. They want to do things, again, we're seeing older patients, they want to do things. The sort of traditional treatment was, for older patients, you don't need an ACL. You're going to be fine, not important. I can tell you personally that I've done ACL reconstruction on an 81-year-old man who's a big-time hiker, and he is the happiest patient I have. His knee was giving out on him, and so you just do what you have to do. And we know that the ACL is protective of the rest of the knee. So these are kind of the big bags of how you can screw things up, really. We're pretty good at the surgical procedure now. We're good at the surgical technique. And rehab, if you ask 10 different orthopedic surgeons how they rehab an ACL, you're going to get 25 different answers. Patient selection, though, is really important. The patient has to be invested, because we can make everything look perfect, and if they don't do the rehab, or if they're doing things that they are too quick, that they're not ready for, it could potentially have a bad outcome. So we need to know how committed they are to their recovery. Are they compliant? What are their goals? And then there is some consideration in terms of timing for seasons. These certainly the high school and the collegiate athletes, are they going to be ready for the next season? Should we wait a little bit in timing and such? So a lot of these are, a couple of these are not necessarily important to you guys. I'm going to talk about graft selection, graft placement and graft fixation. That's sort of nerdy orthopedic stuff. We don't need to get into that. Rehab protocols, I'll sort of go through a little bit of mine. Again, there's a lot of variability to that, bracing and how we know if someone's ready to play or not. So first thing we need to consider is age. There's studies that show that, like I said before, the original treatment was if you tear your ACL over the age of 50, you didn't get anything. You just go home, enjoy it. But there was a study, ages 40 to 60, 83% of those that had their ACL reconstruction were happy and did great. And the amount of activity modification necessary if you don't have the surgery was really something that they did not like. So many patients desired surgery. And then on the other end of it, there's a lot of things to consider with pediatric ACLs. And again, this is a whole big topic I'm just going to go over quickly. But when I see these open growth plates here, it actually changes how we have to fix these. The original teaching with this was if you have a 12-year-old that comes into your office with an ACL tear with open growth plates, they need to wait. They need to wait, and they need to wait until they're done growing before you can do it. And the thought was, in order to reconstruct the ACL, you need to drill a tunnel across the growth plate here and here, and that was going to cause a growth arrest or growth disturbance. What we found, though, is in kids that are 12 that have an ACL tear, and you tell them to stop doing anything, that they get depressed, they put on weight, they're unhappy, and they end up just doing whatever they want to do anyways, and then they tear their meniscus, and then they've got longer-term problems. And so when I see a patient who comes in who has open growth plates, probably still going to fix them. I do want to know a number of things, their Tanner stage, whether they've had periods for the females, what their parents' height are. If the patient comes in and their dad's my height, I got to think about that, because they've got a lot of years of growth ahead of them. So that's why I mentioned concern for growth arrest. There's some ways we've worked around that, and one of the things we do is we use their hamstrings to reconstruct it. And I'll get into the different types of grafts that are used in a minute here, but we found that if you do a soft tissue graft and don't put a big screw right across the growth plate, and try to make the the tunnels a little bit more vertical so they're not at an angle, we can really disrupt the growth plate as little as possible. These patients do fine. The likelihood of them having a growth arrest or growth disturbance is extraordinarily low. You do have to keep an eye on it, though, and oftentimes they'll get x-rays a year out, 2 years out, just to make sure that I didn't cause an iatrogenic growth problem. So this, like I said, it helps patients remain active. We use the hamstrings. There's no screws placed in the ACL tunnel. So there's 3 main graft choices I'm going to talk about. There's a 4th one, but nobody really does it, so I'm not going to skip that one. The first one is we use the central 1/3 of the patellar tendon. This is the way that was sort of first done. Hamstrings tendon, this has been around a long time. All these have excellent results. And then the last one is to use cadaver graft or allograft tissue, meaning from someone else's body who died and donated their body to science. So the patellar tendon, excellent strength, excellent size of the graft. I can make it quite large. Bigger is generally better in this case. More collagen, the better. There's a very low re-tear rate. And that patient knows where the tissue's been its whole life. It's been with them. There's no risk of disease transmission. Works great. There are some downsides to it. There's definitely more kneeling pain. I believe the studies have shown anywhere between 20 and 40% of kneeling pain associated with these, and that can be important for certain types of sports, football, volleyball, where patients are diving under the knees a lot. They may not like that. During the initial time frame, also the patella is a little bit weak. There was a high-profile incident of this. I think it was Jerry Rice back. He came back everybody remember Jerry Rice? He came back a little early from his ACL, and he fell. He had a patellar tendon, and he fell and fractured his patella in half on the field. So this is where we take it from. We want to take the central third, and that gives me about a 10-millimeter bone plug on either side, which is fairly large. We cut that out, and the patients don't miss this. They don't have any patellar tendon weakness afterwards. We don't even have to really sew that back up. I do have to fill bone on this side here and on this side here, because you will notice, especially females, if they're wearing a skirt and they cross their legs, if you don't fill that, they'll notice a defect there. It's very obvious. And so we tend to fill that with bone on both sides, so that fills in. It's more cosmetically pleasing. It is a reasonably large scar across the front of the knee. I can show you mine. I've had this done as well. This is what it looks like on the inside here. Graft comes out about this size. We clean that up and make it into an appropriate size graft. And we go ahead and we put it in, make tunnels in the bone. and hold it in place, and we put little screws in there to hold it in place. Now, you can use metal, you can use different kinds of materials. There's a type that we use called biocomposite, which actually turns into bone over time, which is kind of nice. And I get asked the question at least twice a day, am I going to set off airport security alarms because I have screws in my knees? The answer is no. I've never seen that happen. So a hamstrings graft is also very popular. There's many studies looking at patellar tendon and hamstring side by side. They do great side to side. Excellent outcomes, very strong graft. There's no kneeling pain. It's a little smaller scar, a little more cosmetically pleasing. There are some potential downsides to it. Hamstrings, sometimes you get stuck, they're a little bit small. They're not quite the same size as the patellar tendon. Like I said, size does matter a little bit in this case. So we found different ways to work with this. We take the hamstrings out. They look like long pieces of spaghetti, really. We fold them over and make it into a big graft. We make tunnels in there and hold it in place. One of the potential downsides to taking hamstrings, the overwhelming majority of people don't notice a thing. The one sport where they do is in hurdling, because it's such an awkward position to bring your leg up into hyperflexion and out to the side, and they will have a little bit of weakness with that. I've never actually had anybody else otherwise complain about it. This is what it looks like. There's two different types of incisions you can do. I sort of do this way. I think a couple of my partners do it the other way. We go ahead and we detach two of the hamstrings right at their insertion site, and then we have these long, what we call tendon strippers. We sew the end of the tendon. We take the tendon strippers, we slide it all the way up the back of their leg, and it comes out with these long pieces of spaghetti here. And we go ahead and fold those over and sew them together. We put it on a little bit of tension to pull some of the creep out of it. And then we pull it up in place, and it's held in various different ways. Many, many, many studies looking at these side to side. They all do great in comparison. Now, third choice, allograft tissue, meaning from someone else's body. And there's less pain associated with this because there's no donor site pain. I'm not taking it from anywhere. It's faster surgery, patient feels better faster, but it's not necessarily healing faster. It actually takes a little longer to incorporate. May not heal completely if you look at it biologically. There's a theoretical risk of disease transmission, although the risk is, last I read, was less than 1 in 6 million. And I don't think there's been any disease transmission, HIV, hepatitis, since the early 90s. The way the grafts are processed, that's really kind of a non-issue. The big issue I worry about is patients that are 25 and under and high-end athletes, significantly higher risk of re-tear. 9 versus 25%, this is just one study. There's studies showing significant, even more than this. So in my practice, I usually reserve allograft tissue for less sedentary patient, a little bit older patient, wants to maybe hike, but is not going to be skiing or doing sort of higher end sport, or in patients where I have to revise it and I've run out of other tissue that I can take from them, and I need to just get it from somewhere. This is what it looks like. There's various types of grafts. They can be all soft tissue. They can have bone on either end. This is an allograft patellar tendon. This is not one that I use, but this works great. We pull this into place. This is an arthroscopic picture of what it looks like while it's in the joint. That purple is just us making measurements in there. That's not actually how they come. So there's some technical issues that we need to worry about: where we put our tunnels, where we get the graft from. Is it a strong graft? How do we fix it with screws or buttons, things like that? The important thing that you guys need to know, or I guess all orthopedic surgeons need to know, is most of the time these fail because of technical error. And so we need to really kind of do a good job and put them in the right place. If we do, the patients generally do very well. And that's commonly associated with, does the surgeon do a lot of these? It's like anything. You do a lot of it, you're generally better at it. These are some subjective patient satisfaction scores. These are from all across the types of grafts used. People get better, they feel better subjectively, all in the 90th percentile. Now, it doesn't mean that they don't have a risk of re-tear and they'll all get back to previous level of play, but they generally all feel really good. 85 to 90% of them had a negative pivot shift on exam afterwards. Only 5% had more than 5 millimeters of movement anteriorly on a Lachman's. A KT1000 is a specialized test that's used to sort of mimic your hands performing a Lachman's test. We don't generally use that very often, but that was used for the study to kind of make it more objective. Again, 95% mostly and completely satisfied subjectively. Now, this is the thing that we sort of get dinged on a little bit. Return to previous sport. I just told you how great we are at fixing these, right? 70% get back to previous level of play. And that seems fairly low. There's a lot of reasons why, and some of them are mental. The patient just has fear, doesn't want to go back to previous level of play. Some of them don't feel good enough to go back to play. Some of them, so if I tore my ACL at my age and playing basketball, I would not return to play because I don't have time for that. So there's a lot of reasons that go into it. It doesn't necessarily mean that these are all failing. So how do we rehab these? If you had the surgery 25 years ago, you got a cylindrical cast, you were laid up in bed for 6 weeks, talk to me in 6 weeks. It's completely changed. So I don't even put my patients in a brace post-operatively. I want them to fire their quad as soon as possible. I want them to get up and get moving. We put them on crutches typically for about 2 weeks, but basically until they can walk without a limp. We focus on early range of motion, or early quad sets. I generally have them start physical therapy day 3. One thing I don't use is a CPM machine. You guys familiar with that? It's a continuous passive motion machine. This is something that was used, it's sort of phased out over the past 10 years or so. There are a number of studies, you lay in bed and let the machine bend you slowly up and slowly back down. That's gone away. We've moved away from that. There's a number of studies that show that it made no difference in your range of motion or your outcomes. Avoid open chain quad extension. So what that is the workout machine that you have in the gym where you sit on the end and there's a little bar, you put your legs behind it and you kick your legs forward. We really have patients avoid that because that puts a lot of stress on the graft. And so that's a very common one. We have to kind of get patients away from that. And the way you can build up your quad without doing that is doing things like a leg press. That's a closed chain. It's not putting a lot of stress on the graft. They can do squats, they can do lunges, they can do wall sits. So there's a number of different ways that you can get your quad stronger without doing that activity. Getting on a bike, stationary bike, is as good as anything. So again, there's numerous protocols. That's just a little bit of window into mine. I'm sure my partners in the back have various reasons why they do different things. Return to play, or when you're essentially done, is typically ranges between 6 and 12 months. I tend to tell my patients 8 months, you can go back to play as long as you got all your quad strength back. You can complete an ACL prevention course, and you can do all the sport-specific activities that you must be able to do. The sport-specific stuff with the physical therapist, with their athletic trainer at school. The ACL prevention class, there's one out there called the JUMP program. It's focused on teaching players, patients, how to land appropriately. I showed you that slide earlier with the sort of the valgus landing. It's to try to avoid that. And there's actually studies that show with ACL prevention, if we can get trainers to get basketball players, football players, soccer players, volleyball players to be doing those types of things pre-season, there's a significant decrease in risk of having an ACL tear. So long-term patients don't need a brace. I get this question from every single one of them. It's not necessary. I've had patients re-tear within the brace. There's studies that show that there's no difference in ACL bracing afterwards, whether they're going to re-tear or not. Now, having said that, if a patient wants it for a mental edge, I'm totally fine with it. I don't think there's any problem with putting them in them, but it's just not going to stop it from re-injuring. I don't want them to have a false sense of security. So, biggest complication rate of all these things is re-tear. We can make it great, we can't make it indestructible. But generally, we can make it as good as the other side. There are studies that show anywhere, depending again on the athlete, the patient, the type of graft used, if it was done right, re-tear rates anywhere between 3 and 30%. 30% is real high. That would be more an allograft study. A lot of it depends on their age as well, how active they are. What's really interesting is if you tear your ACL in a non-contact way, you have about a 6% chance of tearing the ACL in your other knee within the next 5 years. That's kind of scary stuff. And so I really make sure patients realize this, that they need to be doing the JUMP program. They need to get on top of this and be careful. These complications are kind of with any surgery we do. They're extraordinarily low. Infection, blood clot, fracture and patellar tendon rupture. That would be if you use a patellar tendon graft. Again, very low, but not zero. We very rarely have to reoperate on these patients for being stiff because we start physical therapy so early. That used to be a big problem a long time ago. The patellar tendon pain, as I mentioned earlier, that's with kneeling more than anything. So in conclusion, ACL injury is very common. More men than women tear their ACLs in general, but women are actually a little bit more susceptible to it. When you see these patients come in, you certainly got to take a good history and physical exam, X-ray to look for other things like fracture, MRI to check to make sure their cartilage isn't damaged or the meniscus. There's a very high association with those kinds of injuries when you tear your ACL. Again, it's mostly athletes, but it's not just athletes. We see everyday people doing this all the time. In general, people do very well with surgery. There's an excellent return to play level, but it's not perfect. There's many different graft choices. The technique and surgeon volume are very important to success. Plenty of various rehab options. Bracing is not necessary. Most have excellent outcomes, but not all of them return to previous level of play, and there is a small but real risk of re-injury. And there's two of the biggest Blazers fans. We'll be there tonight. I don't know if you guys are going to the game. Thank you. Any questions? Yeah.
Intuitively, you think that fixing the ACL would reduce the risk of arthritis later on. Is there data to suggest that?
There's a lot of studies looking at that. We know for sure that if you don't reconstruct the ACL, the risk of developing arthritis is very high and tends to set in about 18.6 years. So if you do reconstruct the ACL, theoretically, it makes sense, but we don't have any studies that show that. So what we do know is if you fix the ACL, the meniscus and the articular cartilage is more protected, so it makes perfect sense, but we just can't prove that. And there could be a lot of reasons for that. There's some biological markers, some chemicals that are released as soon as you tear the ACL that can be associated with bone bruising as well. So there's a lot more that goes into it than just functionally putting it back together. Yeah.
When you're using a bike, stationary bike for rehab, either post-surgery or avoid surgery, speed or resistance, what are you working on?
I just want range of motion more than anything in the early stages. And that's one thing I didn't really bring up, but when a patient tears their ACL, I'm not rushing them right to the OR. I want them to have full range of motion before I take them back to the OR, because we know that if we fix them too quickly, they tend to end up stiff. So the first thing I do when I see them is I try to get them out of the knee immobilizer that they've been put in from the emergency room. We order an MRI, we get them on a stationary bike, and we start what we call ACL prehab to try to get them moving, try to reactivate their quad, which is going to shut down, and get them moving. But in general, with a stationary bike, I just want motion. Yeah.
Question about the ACL prevention class. Is that provided nationally, and is it kind of like classes inside, or is it like he's studying in a gym where they have to participate?
So the question was the ACL prevention. Is this something that's done nationwide, and how you do it? Where can you find it? The answer is yes. It's known all across the country. Our physical therapists, who are phenomenal, that's the last step of the therapy that we always have them do. Every patient that goes through our rehab, the last bit is the jump program. Now, and that happens across the city too. The therapists in general in Portland are fantastic. It can be found online, and I think that there's a big push to get an athletic trainer in all the high schools. That would be fantastic if that happens. I think most of the big ones have them now, and they're certainly aware of it. I don't know if they have time to be able to implement it, but it's something that they're working on, certainly. Yes?
Is there utility of electric muscle stimulators required in the quad?
The question is there any use of electrical stimulation for the quad? No. It feels good. So there's no downside to it, but it doesn't seem to actually do a whole lot. Great. Thank you.